Hello. So, as head injury and spine injury is such a vast topic, so I will not be taking a lot of your time. So, I will try to consolidate as much of information as possible. Most of the things are like things you know previously. So, this will be a sort of revision for you people also. So, coming to definition of head injury. Head injury includes any trauma to the skull or brain tissues. Either it can be singly also or collectively also. Next slide. Coming to some brief epidemiology, in India, the incidence of head injury has increased over the past few decades, mainly due to increased traffic and urbanization. Even though head injury should be primarily managed by neurosurgeons, but in resource-poor country like India, it is not always possible for a neurosurgeon to be present even in the remote areas. So, therefore, all medical practitioners and even common public needs to be aware of the basic knowledge of the head injuries. Head injury in polytrauma cases is the number one killer. 25% of all trauma deaths and 50% of all motor vehicle accidents are involve head injury. Most common age group to be affected is 20 to 40 years, which is a common age group of working males. Males are obviously more prone for developing head injury than females, which is approximately 3 times more. And common causes includes road traffic accidents, falls, or assaults. So these are the few common causes I have highlighted here. Most common cause, as I already told, it is traffic accidents. Next is accident at home, especially in elderly population. Trivial falls at the bathroom and fall from bed are common. Another common cause is a physical assault. So coming to some basic anatomy of the skull. From outside to inside, first is the skull, which has 5 layers, which is a common mnemonic called the skull. That is, first is skin, then connective tissue, then aponeurosis, then loose areolar tissue, followed by pericranium. So out of these 5 layers in L means like a loose areolar tissue. That is the layer in which the blood vessels are there. Followed by skull, there is skull. The meninges, as you know, there are 3 layers: dura mater, arabic mater, and pia mater. Followed by that brain tissue, and inside the brain there is the CSF and blood vessels. So head injuries can be classified in multiple ways. Most commonly used ways are based on duration of unconsciousness, based on Glasgow Coma Score, either open or closed head injury. These are the main modes, ways through which head injuries are classified. So, based on duration of unconsciousness and Glasgow Coma Score, head injury is classified into mild, moderate, and severe. So, mild head injury involves loss of consciousness in less than 30 minutes. Moderate involves 30 minutes to 6 hours, and severe head injury involves loss of consciousness for more than 6 hours. Similarly, mild, moderate, and severe classification is done on the basis of Glasgow Coma Score. 13 to 15 GCS is a mild head injury, 9 to 12 is a moderate head injury, and 3 to 8 involves severe head injury. Open and closed head injury, as the name suggests, is pretty obvious. Open head injury involves penetration to the skull, and closed head injury involves there is no penetration of skull, there is a diffuse injury to the brain. However, we classify the head injuries, we should always remember that no head injury is minor enough to be neglected, nor severe enough to be given up. So, coming to Glasgow Coma Scale, in case of head injuries, level of consciousness is the most reliable clinical indicator for indicating the severity of brain damage. GCS was first introduced in 1974 and then revised in 1978, and since then it has been adopted by neurosurgeons and practitioners all over the world, and it is a fairly reproducible type of scale. But prerequisite for assessing a Glasgow Coma Scale include that patient should not be sedated and patient should not be paralyzed. So this is the Glasgow Coma Scale, as we all know. It involves 3 responses: eye opening, best verbal response, and best motor response. Eye opening has maximum of 4, but best verbal response of maximum of 5, and best motor response of total of 6 scores. So Glasgow Coma Scale has minimum score of 3 and maximum score of 15. Sometimes we have seen some patients referred from some remote PSC and all the case sheet they have been mentioning that Glasgow Coma Score is 0 by 15. So we should always remember that the minimum score of GCS is 3 and maximum is 15. Okay. Here I will be briefly demonstrating how GCS is assessed. Mute. So this is same for control. So here I will be briefly showing you how to assess the GCS of a patient. Click on this one. Save on the desktop. Desktop only is because this is. So here you can see the patient is having, first you will assess the eye response. Here patient is having spontaneous eye opening. Here we are asking him name or asking him to open the eyes, then he is opening the eyes. That is regarded as E3. Then we have to reassess the patient in step by step. First we have to ask verbally, then put some pressure on the sternum to give a painful stimulus. Then he is opening. This is even response, in which patient is neither opening to the spontaneously, neither opening to verbal stimuli or not to the pain also. So this is even response. Then we will be assessing verbal response. So if you ask patient some common questions like what is his name, then he will be telling the name. That is V5. He is oriented in place, time and person. Then this is a disoriented person. In him, suppose we ask him like what is his name, then he will be telling I want water, like that. So he will be telling, he will be confused. He will not be oriented in time, place and person. In D3, he will be having inappropriate words which are not related. He will be speaking, words will be formed but it will not be related. In V2, it will be either single word or patient will be making sounds, inappropriate sounds. In V1, he will not be making any, there will be no response after painful stimulus also. Coming to the motor response, M6 will be, patient will be obeying whatever command you tell them. You ask him to lift his hand, he will be lifting his hand. Other hand also, he will be opening hand, he will be obeying your commands. In M5, patient will be localizing pain. Suppose you are giving some painful stimulus to any area of the body, he will localize that area. We will try to pinch the patient's hand, then he will try to localize that pain with the other hand. This is M5. In M4, patient will be withdrawing to the painful stimulus. And it is also called a normal frictional response. Suppose we are giving the painful stimulus on the hand, he is withdrawing from the pain. This is M3. In M3, patient will be having abnormal frictional response. It is also called as decorticate posture. And upper limb will be in flexion position, lower limb will be in extension position. This is M2 response, in which both upper limbs and lower limbs will be in extension position. It is also called as the decerebrate posture. You can see here both upper limbs and lower limbs are in the extended position. This is M2 response. In M1, there will be no motor response. So this is how you assess the Glasgow Coma score of a patient. So depending on the Glasgow Coma score, we can classify the severity of head injury. Again, we will revise once again. So in eye opening, E4 is spontaneous eye opening, E3 is eye opening to speech, E2 is eye opening to the pressure, to the pain. Painful stimulus we can either give in the sternum, we can even also give in the medial aspect of the eyebrow, or we can also pinch the nail bed. This is the verbal response. In V5, patient will be totally oriented in time, place and person. In V4, he will be disoriented. In V3, it will be inappropriate words, and V2 will be incomprehensible sounds. Only like that sound will be making. And V1 will be having no response. Motor response, M6 is patient is obeying, M5 is localizing the pain, M4 is withdraws to painful stimulus, M3 is abnormal friction or also called as decorticate posture, M2 is decerebrate posture or abnormal extension, and M1 is no motor response. So these are some special situations while assessing the Glasgow Coma scale. Suppose there is an orbital swelling or some orbital fracture. In that case, we cannot assess eye opening. In that case, we have to mention as there is E and T or not tested. While calculating the score, it is considered as value 1. Similarly, when patient is intubated, when he is intubated with endotracheal tube, we generally mention as VET, which indicates that patient is intubated with endotracheal tube. And when the patient is tracheostomized, that time we mention as VT. In case of paraplegic or hemiplegic patient, sometimes motor response cannot be elicited. In that case, we mention the motor not tested. So this is the list of some commonly encountered head injuries in normal clinical practice. We get skull fractures, local injuries, and these are diffuse injuries. So coming to the practical point, what to do on receiving a head injury patient. So as of all the medical and surgical emergencies, we have to follow the ABC protocol. First, we have to take care of the airway. In airway, we have to see whether there is any foreign body there, or look for any loose tooth or fractured jaw. And first of all, we have to maintain the airway while taking care of the cervical spine protection also. So for protecting cervical spine in case of a polytrauma patient, we either use the jaw thrust chin lift manual we use, but if we are suspecting cervical spine injury, we have to use jaw thrust manual. And we have to do thorough oral suctioning also to prevent aspiration. So this is I'm showing here that in normal patient who is lying down, there will be open airway. In patient who is unconscious who is lying down, the airway will be blocked because of the tongue drop. So in case where there is a no spinal injury, in that case we can use the chin lift manual which is shown on the right side. In that case we can just extend the neck and lift the jaw so that the airway will be opened. But in case of suspected cervical spine injury, we cannot do that. In that case, we have to do jaw thrust maneuver, in which we have to place both our fingers behind the ramus of the mandible and tilt the jaw. We have to open the jaw so that the airway will be opened. Next. So we have to do primary survey of the patient first. So in ABC, we have finished, airway we have finished. So coming to breathing, we have to look for the respiration of patient. We have to see whether he is breathing spontaneously and if breathing is adequate or not. How we will assess the adequacy? We have to assess it by checking the saturation of O2 and the status of accessory muscles also. And question arises when to intubate the patient. So if the GCS is less than 8, then regardless of the other parameters, we have to intubate the patient. Or when the patient is gasping, or there is a labored breathing, or there is such a continuous saturation drop. But while intubating also, we have to be aware of the cervical spine injury. Coming to circulation, first of all, we have to obtain an intravenous access and start normal saline. Normal saline is the safest IV fluid to be given in any head injury, because sometimes patient may be diabetic also. We don't have any adjustment. In that case, it is always safer to start with normal saline. We have to maintain the mean arterial pressure of more than 90 mm of Hg. And similarly, you have to look for any associated injuries also. First, urgent intervention which needs to be done in case of a head injury patient after arrival are, we have to presume that all the patients are having spinal injury unless proved otherwise. First, we have to immobilize the neck either by using a hard cervical collar or a Philadelphia collar if it is available in your casualty that you can use. And while transferring the patient, we always have to use this log roll method. So for log roll method, we usually require 4 people. 3 of them will be handling the patient, and one of the person will be taking care of the cervical spine. So while shifting the patient, we always have to use this log roll type of method. We have to keep the airway open and start administering O2. We have to treat the ongoing bleeding and shock. Sometimes patients will be having other associated injuries or major fractures or any visceral trauma that we have to treat. And similarly, we have to prevent aspiration and vomiting and secretions also. We have to keep actively suctioning the nasal and oral pathways. We have to do head elevation. Head elevation, even though it is a simple thing to do, it improves, it helps a lot in a head injury patient. Simple head elevation can reduce the raised ICP in a head injury patient. But while doing head elevation, we have to see whether the cervical spine injury is there or not. After ruling out only, we can give head elevation. While transporting the patient, we have to keep the head in uphill position. The U isn't there, so we have to keep the patient in uphill position always. So while transporting the patient on stretcher, we have to make sure that while climbing up, his head should be up. It should be down so that ICP will not be raised. So these are some few red flag signs in case of a head injury patients. Impaired consciousness level is the most important red flag sign in case of head injury. Plus dilated pupils which do not respond to light, which are fixed and dilated, is a red flag sign. Signs of basal skull fracture, which include the raccoon eyes, we can see in the above picture. Those are raccoon eyes, which is a sign of orbital fracture, and battle sign. The red ecchymosis behind the pinna is called a battle sign. So these are the signs of basal skull fractures. plus any focal neurological deficit or visual disturbances like slurring of speech or any limb weakness or any visual disturbances. These are the signs which are red flag signs in head injury. Similarly, seizure or amnesia, significant headache and nausea and vomiting. So these are the red flag signs. We can have a look at those signs. Next. So coming to patient coming with seizures.
No, important sign is patient is unconscious before lucid.
Are we talking about it next slide? So coming to patient coming with seizure. So as usual in all cases we have to start with airway, breathing and circulation. We have to monitor the saturation and finger stick glucose and IV access we have to get. Finger stick glucose is an important parameter to be monitored because many of the elderly patients coming in cavity with seizures, simple cause will be just hypoglycemia. So that we can treat with administering dextrose. So that we have to see in all seizing patients. So saturation and finger stick glucose we have to see in all the patients. Then we have to give thiamine 100 mg IV, especially in alcoholic people, followed by dextrose infusion. So if a patient is alcoholic and we directly give him dextrose infusion, there are high chances that he will end up in morphinic psychosis. So in that case, we have to give thiamine first, followed by dextrose infusion. Do not give directly the dextrose infusion. Then for stopping the seizures, antiepileptics we have to give, of which drug of choice will be lorazepam, 4 mg IV for adults. But in majority of the setups, lorazepam is not easily available. So what we generally use phenytoin only, for which loading dose is around 15 mg per kg IV, which comes roughly around 1 gram. So 1 gram we have to give IV stat, followed by maintenance dose we have to give at 100 mg TDS. If there is no response in 20 minutes, then we have to repeat the phenytoin again at 10 mg per kg. Next slide. What if there is no IV access? Sometimes patients come in a shop. In that case, we cannot find IV access. So in that case, we can give IM injection also. For giving IM, we have to use injection midazolam 10 mg. 10 mg intramuscular we have to give. And suppose all the above medications have not stopped the seizures. In that case, we have to give injection sodium valproate or injection phenobarbital or levetiracetam we can use. If seizures continues even after 30 minutes and they are refractory to both first line and second line also, in that case we can give injection midazolam 0.2 mg per kg per IV loading dose, followed by 0.2 mg per kg per hour infusion. So that will sedate the patient completely. So coming to then to refer the patient of head injury. So if the GCS is less than 15 on initial assessment, GCS is 15 but red flag signs are present, all the red flag signs we have referred earlier, or is there any previous cranial neurosurgical intervention done? Just like some patient will be having a cranial defect or some patient will be having some implant. In that case, we can refer. There is a high energy head injury. High energy head injury involves like a motor vehicle accidents or any mechanical device, mechanical instruments injury that includes under high energy head injuries. If there is an history of bleeding or clotting disorders, so those patients who are having with thrombophilia or sickle cell, those cases, or there is any current anticoagulant or antibiotic therapy except aspirin monotherapy. Suppose patient is on single aspirin, that is not like immediate indication to refer. But if he is on aspirin plus copated, which is majority of the cases nowadays, in that case we have to refer. Patient is intoxicated or in under alcohol influence, in that case, or there is a irritability or altered behavior, particularly in babies and children under 5. And lastly, there is a continuing concern by the professional about diagnosis. This simply means that suppose you are in doubt, then you refer. Don't What about children? So in children, we have to see all the red flag signs as we see in the adults. Plus, we have to see for changes in the children's behavior also. Finding the clinical signs in children will be somewhat trickier as compared to adults. So child may be lethargic or difficult to wake, extremely irritable, confused, or exhibiting abnormal behavior, throwing objects and all. So if the child stumbles or difficulty walking, there is clumsiness or lack of coordination in children, in that case we can refer the children. And if there is a bloody or watery ooze from the nose or ear, that indicates a basal skull fracture. If the child is younger than 6 months of age, it is always better to refer the child. If the child is fall from height greater than 3 to 5 feet, first floor, fall from first floor or second floor, or fall from stairs, so which is greater than 3 to 5 feet, in that case we can refer the child. If the parent or caregiver is concerned about how the child is acting, that is also an indication for referring the patient. So when to do CT training in a patient of head injury? So for that there are the Canadian CT head rule guidelines which have been described, in which CT head is only required for minor head injury patients with any one of the following things. So DCS is less than 15 at 2 hours after injury, suspected open or depressed skull fracture, any signs of basal skull fracture, vomiting more than 2 episodes. Single episode of vomiting is usually not a big concern. So multiple episodes are the concerns, and age more than 65 years. These are the high risk category in which we have to do CT scan. Plus there are medium risk categories like amnesia and dangerous mechanisms like pedestrian occupant ejected, fall from injury turn like that. So these are the criteria in which we have to perform a CT therapy. Next slide. Now comes the secondary survey. The secondary survey should be done only after stabilizing the patient. It's only after primary survey we have to go for secondary survey. This involves detailed examination of the head injury patient. So neurological evaluation is the single most comprehensive process in the diagnosis and evaluation of head injury. It is even more important than CT scan and MRI also. It will help us to prognosticate the patient. What are the goals of secondary survey? First is there a head injury or not, that we have to identify. Does it need treatment or there is any associated injury? These three things you have to find after secondary survey. So history wise we have to find a reliable witness first, either a relative or bystander. Then precise time we need to find, which is both important from medical legal as well as therapeutic aspect. Then mechanism of injury is a very important factor, which will indicate that what type of injury we are dealing with. That will indicate that thing. And then there are usual warning signs like loss of consciousness, seizure, vomiting, ENT bleed, drug or alcohol intakes, and obviously comorbidities we have to take care of. Vital signs we have to monitor: pulse rate, BP, respiration, and saturation. We all must be aware of the Cushing's triad in head injury, which involves bradycardia, hypertension, and irregular respiration. So this triad is classical of intracranial mass. Or in case of head injury, suppose some hematoma is developing, this triad will be classically present in case of head injury patients. Next slide. If a head injury patient is having hypotension, you should look for spine injury or any ongoing blood loss. So isolated cranial injury patient do not cause hypotension. This thing you should always remember. If a patient is having hypotension and we are suspecting head injury, so hypotension is very less likely that it could be because of some other injury or could be because of spinal injury. Next slide. So these are three general thumb rules we have to remember. Suppose patient is presenting with hypertension with bradycardia, which are the components of Cushing triad as we know. That indicates intracranial mass like hematoma or any other expanding mass in the brain. Suppose patient is presenting with hypotension and bradycardia, that is usually present in cervical spine injury. And if the patient is having hypotension and tachycardia, this indicates ongoing blood loss in the body. It could be abdominal injury or thoracic injury or could be any major fracture. Next slide, please. So in general examination, we have to see whether there are any scalp wounds, any ENT or CSF, ENT bleed is there or CSF bleed is there. As we already told, Bracon eyes, vital signs we have to look for, facial palsy or asymmetry or irregularity of the bony margin, especially on the supraorbital region, we have to keep on palpating if there is any irregularity of the bone. Then in case of spine also, we have to see the spinal alignment or any tenderness, as just now I told in the beginning, that way we have to see the spinal tenderness. Next slide. The level of consciousness and memory we have to assess. Coming to the examination of eyes, eyes are called as windows to the brain, so we have to be thorough in the examination of eyes. We have to see the pupils. So before examining the pupil, you should remember that do not put mydriatic eye drop before neurological assessment. It will hamper the neurological assessment of the patient. Then how to examine the pupil? I have put a short video there. It's a brief video of few seconds only. It will just give a, as all people already know, it's just a revision. So the room should be dimly lit, and we have to use diffuse light, and we have to throw the light either from temporal direction or from infrared direction. Then we have to notice the size, shape, and position of the pupil. First, we have to see the direct reflex. While putting light in the eye, the same side pupil will be constricting. We have to notice the speed of the constriction also. So we can see here normally constricting pupil. Then comes the consensual reflex, in which We throw light in one eye and the other side people gets constricted. That is a consensual reflex. Then there are multiple pathological reflexes like relative afferent pupillary defect, RAPD we call it. But those are not like usually encountered in the practice. The commonly encountered is the anisocoria, in which the one side pupil there will be asymmetry in the shape of pupils of the both sides. So next. Then we have to examine the extraocular movements of the patient. While examining the extraocular movement, we have to examine one eye at a time, and we have to examine along the imaginary H shape. Like we have to see superiorly first, then laterally, then inferiorly, then opposite side superiorly, middle, and inferiorly. So there will be an H imaginary. So we have to see whether there is any deviation of eyeball or any weakness is there. Then comes the dorsal movements. Dorsal movements are used in the patient in comatose state. In that case also we have to first rule out any cervical spine injury. Then we have to open the eyelids with the thumb and index finger and rotate the neck horizontally. So just like a dog, the eyes will be moving. So that is the indication of functioning brainstem if dorsal movements are present. Next slide. Next slide, please. And then comes the verbal response. We have already seen the Glasgow Coma scale how to assess the verbal response. We have to see whether the patient is oriented or not. We have to see his memory also. Then motor response. We have to see DCS motor response first. Followed by there is a medical research council grading. As we all know, there is a 5 grades of power of muscle. We can assess the degree of weakness and compare the degree with on the both sides. Next slide, please. As I already told, this is the list of commonly encountered head injuries in clinical practice. We'll briefly go through one slide through those. So minor head injury is defined as DCS more than 12, or there is no abnormality on CT scan. So most commonly encountered injuries in your clinical practice will be scalp injuries. So the scalp, as I already told, it has the richest subcutaneous vascular supply in body, and when lacerated, small arteries in the scalp they tend to retract. So it is difficult to control the bleeding in scalp. So even a 7 to 10 centimeter of laceration of scalp can cause blood loss of more than 30% blood volume also sometimes. So what to do in case of scalp lacerations? So first we have to do the thorough saline wash to remove all the dirt and debris. Then we have to expose the wound properly by doing head shaving and all. We have to expose all the edges. Then we have to attain the bleeding control, which can be attained by giving head elevation. We have to rule out the fracture also. It can be done that by palpating with the gloved finger. Then the direct constant pressure we can put on the edges to reduce the bleeding. Then if any artery or any spoiler is visible, that we can clamp with the mosquito corset. Then ultimately we have to do dressing, and then sutures or staples we can put to arrest the bleeding. Next. These are the commonly encountered types of fractures. There is a linear fracture, which is just a crack in the skull we can see. Then terminated fractures involve multiple fragments of the skull bone. Then depressed fracture involves depression of the fracture fragment inside the skull. And basilar fractures involve fracture of the skull base. Next. So fractures are 8% of all traumatic injuries. And most of the times there is positive history of ENT bleed. Suppose there is history of nose bleed, then most likely ethmoid fracture can be there. Then ear bleed, it can be temporal bone fracture. Usually it is associated with underlying fracture, hematoma or EDH also. Linear fractures without significant EDH require conservative management only. And depressed and compound fractures usually require surgical intervention. Then EDH is the one common condition coming in the head injury patients. These are, as we all know, it is mainly arterial bleed and usually associated with fractures, and there is a rapid deterioration of consciousness in case of EDH. There is a thing called as lucid interval, which is common in case of EDH. But however, we should know that lucid interval is not pathognomonic of EDH. It can be found in other conditions also, and in EDH also only 20 to 50% of the patients will be having lucid interval. So what is lucid interval? Initially, a patient will be confused or there will be loss of consciousness in EDH, and followed by a brief period of full consciousness. Patient will be fully mobile, he will be normally talking, he will be conscious oriented. Followed by there will be confusion, somnolence, and then development of neurological deficit in that patient. Then comes subdural hematoma, which is usually due to rupture of the cortical veins, rupture of the bridging veins in the arachnoid, and patients who are on anticoagulation are more prone, especially old age patients are more prone on developing subdural hematomas. It can be either acute, subacute, or chronic. The same type of subdural hematoma you can see in the pictures. It can, over the period of time, it can progress into acute, subacute to ultimately chronic SDH. Then commonly encountered are contusions. So contusions are nothing but a combination of SDH, EDH, and intercranial bleed also. In short, those are the bruise of the cortical surfaces. Those are generally located near the bony prominences like basifrontal region or the temporal polar region. There are more commonly found in hypertensive alcoholic or patients on with bleeding diaphysis. Then comes ICH or IVH. ICH is intracerebral bleed and IVH is intraventricular bleed. ICH is most common in hypertension, especially in the gangliocapsular region, and it may range across various sizes and it may extend into ventricles also. Then comes diffuse type of injury. It involves concussion and diffuse abdominal injury. Concussion is just temporary neurological deficit caused by trauma. So generally in these cases, CT will be normal, and it is generally associated with retrograde amnesia, and morbidity and mortality of this patient depends on the other associated brain injuries. Suppose some contusion is there or some SDH is there. In that case, prognosis may be worse. Next. Diffuse abdominal injury primarily affects white matter tracts in brain. It results from sudden acceleration, deceleration leading to shearing of white matter tracts, and usually prognosis is poorer in case of diffuse abdominal injury cases. I will not go into details of spinal trauma. I will be talking about pathological fractures of the spine, which are very common in the clinical practice, especially in older ladies who are osteoporotic. So, pathological fractures result from underlying disease process that affect the spine. They are common. Yes, they are common and frequent in the elderly, and caused by either osteoporosis or osteomyelitis. Also in TV spine, also we can frequently see the spinal pathological fractures. Next slide. The gold standard for diagnosing osteoporosis utilizes bone mineral density measurements, and bisphosphonates are the first line treatments. For pathological fractures of vertebra, kyphoplasty and vertebroplasty are the available options we frequently do. So vertebroplasty involves the injection of a needle inside the collapsed vertebral body and injection of bone cement. It will restore the curvature of the spine. Kyphoplasty also is a similar procedure which involves inflating a glass-like material balloon followed by injection of cement. So both of these procedures are we usually routinely perform these procedures, and those are commonly performed procedures. So take home message from this presentation will be: we should be able to identify the nature of head injury and classify it according to mildly, moderate, or severe. We should be aware of all the red flag signs in head and spinal injuries, as I already told, and practitioners should be able to do the primary treatment of mild and moderate injuries. For severe injury, definitely we need to refer the patient. Also, we need to identify when to refer the patient and identify when to do imaging in the patients. So, usually the neurotrauma managements we usually perform are the EDH. You can see the intra picture of EDH here. There is a blood clot in the extradural region. Next slide. This is the acute SDH we are dealing with. Dura has been opened, the blood is lying down below the dura, and ready to be fresh bleed it is. Next. For chronic SDH, we do burr hole and evacuation. So you can see on the two burr holes are placed, and drain has been placed in the post-op kitchen. This is the picture of depressed fracture. This is how intraoperative picture of the fracture looks. So we usually remove the fracture fragments, and if they are viable, we can replace it back with the plates and screws also. Or if defect is sufficiently larger and bone fragments are not available, we can put synthetic material like PMMA. We put bone cement like graft we can put, or we can put titanium mesh also. Next slide. This is the intraoperative picture of the cerebral contusion. Next slide. Other conservative cases also we treat usually involves diffuse abdominal injury, concussion. We also do external ventricular drainage for IVH cases, and emergency spinal procedures also we perform. And as I already told, kyphoplasty and vertebroplasty are also they are routinely done by us in for pathological vertebral fractures. Next slide. That's all. Thank you, sir.
That was wonderful, Vaibhav. We have a guest from Kenya, Dr. Patel. He is a big surgeon in Kenya for the last 20 years. Please come over and hand over moment to Dr. Vaibhav.
Last 40 years.
Last 40 years in Kenya as a big time surgeon. Please hand over. Action replay. Thank you very much. All of you had your coffee and all the stuff. It's all over. So thank you very much for coming. I think you had a wonderful time. Shyam, that was amazing, amazing. We really enjoyed the entire neurology. I was thinking neurology is really tough. It's not. It is that tough after hearing it. But some of the procedures are amazing. What we studied in 1970s and all. Absolute knowledge. Absolutely gone. Nothing. It's
1%.
2 centimeters pole which if you can do such wonderful things, that is amazing. So thank you much. Thank you very much for giving this feast of information to all of us. Thank you very much, ladies and gentlemen. We'll meet next month. Bye bye.
We can take Glasgow from our how it is very from here.